invite you to the microphones for a discussion, questions. Patrick.
Good morning. Thank you to all of you. Jason, in the study that you did, it seems that now that the government has decided how much a qual or a qual is worth, and you've shown how much improvement in qual you get, I would think that the next step would be to apply the cost of your therapy and to show for each dollar spent on therapy what's the value of the qual that came from that. Have you done that part?
Yeah, no, that is 100% the next step. So this is only the very first stage. The next stage is then to get enough patients to make it a little bit more, so we can do subgroup. So I don't want to just do qual for a 10-year-old versus a 60-year-old. And then we're going to look at how much money patients have spent with us personally. So how much a checkup was, how much they spent on treatment, equipment they had to buy, as much information we can get from them. And then we'll do with the EQ5D to see, actually, is it cost effective? I have no idea yet. I would hope it would be, because treatment isn't that expensive in relation to a lot of other methods, so with surgery itself. And especially with Mr. Glassman presented, there's no cost effectiveness of adult treatment with surgery, so they're going to look for another option.
Great, thank you.
Renee?
Thank you. I have a question, questions to the first and the third presentation, Mrs. Zur. Thank you very much. Enjoyed the presentation. In my mind, I'm a surgeon, but in my mind, pain in scoliosis is a sort of a self-limiting problem, as I see it. But I may have wrong focus on the problem of pain, because we inflict pain every day. So maybe we should look at it differently. But it seems to me that pain is a self-limiting problem in scoliosis, and the only curves that I really see pain in are the decompensated thoracolumbar curves, so what we call the Lenke 5 curves. And I think in your analysis you didn't show any correlation with curve type and pain. Is that correct? Did I pick that up correct? The curve
Yes.
type and the pain?
Yes, we tried to, but there was no correlation in pain and the curve.
So all types of curves experience the same amount of pain, is what you're saying?
Yes.
Okay, so that's new information for me. And the other thing is that in your third study you showed the effect of the treatment, but shouldn't you ideally have had a control group without your type of treatment to see what would happen to the different domains of the SRS score? Would that not have been a better setup of the study?
Yes, we
Difficult
would
to execute, I understand.
Yes, we would like to have this control group, but it was not possible now. But maybe for the future it would be a good.
And final question, because Eric is getting impatient. But did you admit the patients? Was it inpatient treatment for 2 weeks? Is that right?
No, it's outpatient.
Okay, thank you.
Eric?
My question is for Sabrina. Can you expand a little bit on the content generation? So how did you generate the items?
Yes, we create a tag cloud with the main words used in the blog, selecting the patient for age and pathology. We have this internet blog in which patient can ask questions and communicate each other, but mainly there are parents and patients. So we selected the comments of the boys and girls and find out with this tag cloud the main items. After that, we create a sort of questionnaire with asking to the expert which items they consider in a lighter scale, so if they consider that item very important or not. And after that we create the first version of the questionnaires with about 20 questions, and then the last one has about 10, I think, I don't remember correctly the number, between 15 and 10 questions.
Okay.
Already divided between exercise, no brace and brace.
Okay. So on your blog, what is the geographic representation, and maybe do we know if these patients were already in care or they're just an interest for scoliosis? And are parents and families represented?
No, they are in care, because mainly we invite them to comment in the blog. They comment about their pathology. So they are patients with spinal deformities already treated or at the beginning of the treatment. No, not before. Not worrying about what scoliosis is, but already treated, and so wondering what and how to manage the problem.
And it was patients only, not families or other members of their...
No, we selected only because we can, they register to the website, so we can arrive to the age of people writing, and so we were able to manage and select only patients' comments.
Then why split the questions for bracing versus exercise? Does that create a problem for a patient that moves from one category to the next? Are we able to continue following them with the questionnaire?
Yes, yes, you can. You are able to measure. I don't know exactly what is the formulas which allow this, because a statistician made this calculation. But then you can you have the percentage of health-related quality of life, and it is reliable, and you can compare no brace and brace. So you can see the differences.
So if I understand correctly, the questions used are different, but the score
yes,
is interpreted continuously.
You have the questionnaires divided in two parts. The first part is for no brace, and the last 5 or 6 questions are related to brace. So if you have no brace patient, you complete the first part. If you have brace patient, they complete all. And then you have a percentage of the health-related quality of life adjusted for the treatment.
Michael?
Sabrina, quick question. Do you have an idea how young children, maybe under 11, for example?
No, we select the comments of adolescent patient. So the questionnaire is now validated on adolescent patients, and it was developed for adolescent patients. So no below 11 years of age.
Will you be able to extend it into adulthood? Would it be generalizable to follow long-term?
Yes, we have various steps. The first step was to compare this questionnaire with the SRS 22, and the further step is to validate the questionnaire in other languages, and after that we can expand the questionnaire to adults and other age and also different pathologies. So this questionnaire was developed for spinal deformities, so included hyperkyphosis and scoliosis. But then we can divide and verify if it is able to discriminate differences between hyperkyphotic and scoliotic patient, for example, or other kind of treated. And maybe we can also try to test it for surgically treated patients. But now we have SRS 22, which was specifically developed for surgically treated patients, so we don't have this need. We lack a questionnaire for conservatively treated patient, so this will be the main field of research.
Are the questions so specific that we couldn't normalize to a normal population?
No, I don't think for a normal population, because the questionnaires are very specific, because they deal with all the items related to quality of life, related to the diagnosis. So I don't think for a health population.
If I may ask a few questions. Jason, first of all, congratulations on your work. I'm really excited to see, because it's very important to do. I was just curious as to whether or not you've had any discussion with NHS or WHO or any other similar organization to see whether they would accept this type of transfer from your quality of life into your economic cost.
At this point, we've been working with a health economist who used to work for NICE, and he's been giving us a bit of guidance into really the steps we need to take. And the first step was to actually have some data and some cost effectiveness, and then go to them, because if you go to the door and knock on it, they'll probably turn you away. I'm really open to anyone that has any history working with it, WHO or NICE, because it's not just, we're not limiting it to just our therapy, we're limiting it to anyone who has SRS 30 data can then work with the EQ5D and then use it. So I'm open to any ideas that people have moving.
And for Mariette, just 2 questions. I would agree with Renee that I was quite surprised by your findings. And certainly from our perspective, with tens of thousands of patients, I would not expect to get that, your first paper, in terms of everybody would have pain right across, no matter what their curve type was. So the first question I had with that is that, did you select your patient, the 71 women, or were they a consecutive series of 71 women? How did you end up with the 71 women?
Just with the in and exclusion criteria.
Before the exclusion criteria, how did you select those 71 women?
We made a total base, and then it's all the patients we saw in the last 5 years, I think. And then.
So all of the patients in the last 5 years, and you just used the exclusion criteria, and then ended up with your 71 women?
Yes.
Okay. Now having gone through that, did you find that surprising to yourself as well, the results?
That there was pain in every...
Yeah, that it was right across the board?
Yeah, maybe I was not totally clear, but we see a pain is not related to any... There's no correlation between the type of scoliosis and the pain. Maybe, for example, we see very small cup angles and a lot of pain, and very big cup angles with no pain, or in a different way. Or in the opposite.
Do you think there's another assessment tool that you use to help determine what that variability that you may see, other than what you used?
Sorry, can you repeat?
Do you believe that there was any other type of assessment you should probably use to better find what you expect to see when you deal with the patient?
No, if we thought there was, we used, I think.
Any other questions, comments? Eric?
Maybe I'll just go with a small comment. I think one of the things we see with private clinics is the patients self-select when they have a problem. And so the physiotherapists that have direct access probably have an over-representation of scoliosis with pain because they self-select to go knock on your door. When we did a review of how many were referred out of our specialized scoliosis program, only 15% were referred to physiotherapy with possibly a reason for pain. When we surveyed the therapists to see what are you pursuing for goals when a patient with scoliosis knocks on your door, pain was definitely higher in terms of a goal pursued than we expected based on what the referral patterns was. But that probably represents a large pool of who comes and knock on your door.
Okay, well thank you again, and thank you for the presenters, and we'll go on to the next session now.